Good afternoon, everybody. This is Dr. Mervat Aboulmaaty. I'm a professor of cardiology, consultant of electrophysiology at Ain Shams University, one of the biggest universities in Egypt. It's my pleasure to present to you this presentation, which is talking about from P-wave morphology to the site of origin of focal atrial tachycardia. As we all know, the sinus node is the pacemaker of the heart. It lies in the junction of the superior vena cava and the right atrium, and the impulse depolarizes the right atrium first, then the left atrium. What we can see, if a focal atrial focus is firing, it can arise from any site in the atrium. Here is the embryology of the sinus node. The sinus node is an oval structure, 15 by 5 by 1.5 millimeter. It is a subepicardial structure. The normal P wave is 2.5 millimeter in height and 0.12 second, which in short it is 2.5 squares, small squares in height and in duration. The P wave axis, we can see it also sometimes written in the ECG. The P wave which arises from the SO node on the right side. The P wave axis the P wave is positive in the inferior leads, negative in AVR, and biphasic in V1. And as we can see in this diagram, the P wave morphology is best seen in lead 2 and V1. And in normal, we can see the first part is the right atrial activation or depolarization, and the second part is the left atrium. And this makes this rounded shape in lead 2 with the dimensions I mentioned. In V1, we can see that the positive part, it is positive, negative. The positive part represents the right atrial depolarization, and the negative part, the left atrial depolarization. In presence of right atrial enlargement, the P wave is high up. It is peaked in lead 2 and mainly positive. The positive part is bigger than the negative part in V1. When we have left atrial enlargement, then the second part of the P wave in lead 2 is the bigger one, and this makes it shape or bifid P wave, and the negative part in V1 is bigger, and this makes it this shape. Yes. Here we can see it on the ECG. This is the P wave, the right atrial enlargement, the peaked one in limb lead, and in the V1, the right atrial enlargement, how it looks like. And this is the bifid P wave in left atrial enlargement, and the more negative part in V1. In this study, which was published in 2006, they studied the P wave morphology in focal atrial tachycardia, and from this study, they developed an algorithm to predict the focal origin of the tachycardia. We can see here in this algorithm, they depended on V1. Being negative is right side focus, being positive is left side, and in between, positive, negative, the crista terminalis, negative, positive, they look secondary to the limb leads, mainly AVL, and thereafter they can detect in limb lead 2 and V1 and so forth. And from this study, they estimated the percentage of focal atrial tachycardia, and they said that 73% of focal atrial tachycardia arise from the right atrium and 27% from the left atrium. And from the right atrium, crista terminalis, perinodal tissues, right atrial septum, CS os, ostium, and tricuspid annulus, they are as distributed here. From the left side, we have the left-sided pulmonary veins, the CS body, the left septum representing, and also the superior mitral annulus. We use a simple algorithm to localize the focus of focal atrial tachycardia. Very simple. We look at V1. If it is negative, completely negative, so the origin is from the right atrium. And we look at AVL to confirm. If positive, it's still the specificity can reach up 76%. We look at the P wave. If it is completely positive, so we are talking about origin from the left atrium. And we look at AVL, and this is confirmed by negative P wave in AVL. Then we look at the focus superior and inferior from the limb bleeds. When the limb bleeds are all positive, then this is a superior focus. When they are all negative, this is an inferior focus. This is a very simple algorithm we use, and طبعا of course from the catheter we can identify where the focus is. Then we go to this sophisticated algorithm in order to help us localize the focus with the ECG before we go in depth. Now I'm going to share with you some of these cases which we did at Ain Shams University. This case is a 7-year-old female patient who presented with persistent tachycardia for 6 months, and her ejection fraction started to drop to 30%, and she had tachycardia-induced cardiomyopathy. This is the ECG presented to us, this girl, and we can see that we look at the V1 and we can see that the P wave is positive. So this is left side. And we looked at the limb bleeds and they are all positive. So this is the focus from the left side high up, from the left atrium high up. And we were lucky enough to see this ECG which showed 2-to-1 block during the tachycardia, and then the P wave is clearly demonstrated and seen. And here in V1 positive in V1 and positive in the inferior leads 2, 3 and AVF. So this is left atrial tachycardia from high up. Yes, and these are the arrows pointing to the P wave. This girl had multiple ECGs. One of them was misdiagnosed as sinus, although it was the same morphology of her atrial tachycardia, but it slowed down with the multiple medications she was receiving. Because we have limited resources in Egypt, we use our simple Aboulmaaty technique, conventional ablation of atrial tachycardia, and we use all the measures in the EP lab the conventional way. This is in the EP lab using the St. Jude machine and 12-lead ECG, and then we did transeptal puncture, and we went to the left atrium, and we started mapping in the left-sided pulmonary veins, and then we went into the left atrium itself, and we got a very good signal, 69 milliseconds before the P wave. This is the decapolar catheter inserted in order to see some other signals in the site. And we delivered the RF current at this site, and we terminated the tachycardia successfully. And this is the site where we ablated it. And from this diagram, we diagnosed that we ablated her at the ligament of Marshall. And we have some good cases with atrial tachycardia arising from the ligament of Marshall. This is the left anterior oblique view, and this is the right anterior oblique view looking posteriorly. This is the ligament of Marshall, which is the extension of the ridge between the left atrium and the pulmonary veins, and ends up here in the body of the CS. And there is a lot of research nowadays going to inject alcohol in the vein of Marshall in order to ablate the posterior wall of the left atrium in atrial fibrillation, persistent atrial fibrillation. This is on follow-up. The ejection fraction improved, and the patient was remaining in normal sinus rhythm, lucky enough. This second case is an interesting one with a 10-year-old female patient with paroxysmal atrial tachycardia, normal echocardiography. And here, this is the 12-lead ECG. Looking at V1, actually, it was not completely positive, not completely negative. It was positive, negative. But the inferior leads were all negative, 2, 3, and AVF. We diagnosed her as possible from the CS ostium. Here, we placed the catheter, the decapolar catheter in the CS. Actually, we marked the label, we labeled the CS from 1, 2 down 9, 10, and RV catheter. And we started to confirm that this is atrial tachycardia by ventricular pacing at faster rate than the atrial tachycardia rate to make VA dissociation and confirm the diagnosis of atrial tachycardia. In this case, we were lucky to use the Carto machine, and because from the ECG we said this is from the CS, and then we did activation map, and the earliest focus was at the CS. We can see the yellow one is the HIS, and this is the posterior one is the CS, and we ablated here at this site. Of course, we are using also local electrogram signals, and we got very early signal at the CSOS ablation. We use a Ricardo irrigated tip catheter, and we terminated the tachycardia. This is another nice case of a 5-year-old female patient with persistent focal atrial tachycardia and normal echocardiogram, and we can see localizing here V1 completely positive and negative P wave in the inferior leads. So this is positive V1 from the left side and negative in limb leads, inferior leads. This is from left side and below. So this is the 12-lead ECG during the EP study. We try to do her conventional. We use this 20-pole catheter, we call it halo catheter, poles, 6 poles here inside the CS, and the other one mapping the right side, and this is the Hayes catheter, and this is the ablation catheter trying to map at the CS ostium. We tried to map at the right side, we could not, although of course it is left side, we started there, we went to the CS os, but we could not get good signal, so we did transeptal puncture. Actually, we do the transeptal puncture without ice. We don't have this ice even in any lab in Egypt. And we went to the left side, and we mapped the left pulmonary vein, but the signal was not that early. But here we can see that when we made this maneuver to map the right inferior pulmonary vein, we got better signal, and we got a very good signal, minus 37 milliseconds, and we delivered our energy, and the patient was in sinus rhythm. However, on follow-up, we did post-ablation study. On follow-up, she had recurrence, and we know that there is high recurrence of atrial tachycardia in children. So another procedure, we could manage to provide us, the hospital, with 3D mapping. And here you can see the cartomap. This is the PA view, that this is the right inferior pulmonary vein. We got the early signals here, and we did ablation and isolation of this pulmonary vein, this right side pulmonary vein alone. This is the tachycardia. We got very early signals here, as we see here, minus 35 before the P wave, and we ablated it, and we got normal sinus rhythm. This is the fourth case, which was very nice one. Very, very nice. This is a boy in the middle of these old girls, 14-year-old boy with ectopic atrial tachycardia for 8 months. And he developed cardiomyopathy, ejection fraction 25%. Only we could slow down the ventricular rate by digoxin. And we can see that this atrial tachycardia is running with Winkelbach periodicity, as you see. P wave, PR, PR, P dropped, PR, and so forth. From medication he was in. We looked at the P wave in V1, and there was a completely negative P wave in V1, and negative also 2, 3, and AVF. So this is a right-sided atrial tachycardia. In this case, we placed this halo catheter, 20-pole catheter, into the right side, and also another, we used the CS catheter, we didn't need it because all signals were late, and we used it in the right side. And then we went with this ablation catheter to this site, and we found early signal. We terminated the tachycardia by delivering energy, and we could not induce it again. However, after recurrence, we had to go back, and we could get 3D cartomapping, and this is the atrial lateral wall of the right atrium near the appendage, base of the appendage, and we ablated here, and we terminated tachycardia. Follow-up of this young man was done, and we could get very good result, and his ejection fraction was normal, and his ECG became normal. To sum up, P wave morphology can be seen in V1 and in the inferior leads in sinus rhythm. In order to localize the focal atrial tachycardia, we have to use our surface ECG, and simple way to go through is to look at V1. If it is negative, this is right side focus from the right atrium. If it is positive, this is a left side atrium, left atrium. Then look at the inferior leads, limb leads, if they are positive, up, so this is a high focus, and if they look down, negative, it is a down focus. This is, we can find it easily. Of course, we go by EP, by measurements, by 3D, and then we ablate, and we follow up, and this will end, of course, in success. Thank you very much.